Okay, we're live. Hi, this is Elliot Fishman, and welcome to our weekly Facebook Live. And today we have a special treat. I'm with Samira Farrow, who's the Director of Reader Operations at Imaging Endpoints. And, you know, when we do these Facebook Lives, we also ask people about what they would like to see. And so for us, it's really good that many of the people will say that they're interested in seeing a lot about RECIST reads, because we haven't discussed that a lot. And I thought I would go to the source, and Samira is going to share with us her experience and her knowledge. Welcome, Samira.
Hi, thank you so much. Glad to be here with you. So some general information about RECIST is RECIST stands for Response Evaluation Criteria in Solid Tumors. And the way it's assessed is usually like the version 1.1, radiologists should select 5 targets and then uh, the maximum of 5 target and a maximum of 2 targets per organ. And they have a size criteria to select these target lesions, which is 10 mm long axis for non-nodal lesions and 15 mm short axis for nodal lesions. And then the sum of longest diameters will be calculated to represent the overall tumor burden.
So
So.
let me go back a little bit, because some of the people who are on the call are technologists. They're probably not as familiar with RECIST reads. A lot of the radiologists are. Some of them do it, some of them don't. But let's go back to uh, RECIST 1.0, or really what I mean to say is, why do we do RECIST reads? What is it for? What is the purpose of doing it?
So it's a guidance that we usually use to see how to evaluate and which evaluate and guide researchers to see how the patients are responding to the treatment, and how also to predict the outcome of the patient. So that's a way that is used in clinical trials. Um, it's a tumor response rate that is being measured this way to see how the patients are responding to the treatment. And
Right. So just so for everyone, obviously we all read, a big part of CT is oncology, no matter where you are, whether you're at a Hopkins or a small hospital. And typically, the clinicians want to know how things are going, but it's not good enough to say it looks bigger, it looks smaller. You really need to quantify things. And a lot of the work you do, and maybe you can explain to people, relates to trials and the FDA and things like that, correct?
yes, so the way that it's been done is that it's reliably measured, and it's clinically like meaningful. So um, according to FDA, actually this objective tumor response rate has been the most commonly used surrogate endpoint in support of anti-cancer drug approval. And majority of these clinical trials are using these that use objective tumor response in solid tumors, are using RECIST. So it's uh, it's a way that it's not just saying that the tumor is getting smaller or bigger, but considering the overall tumor and also like the percentage of change over time comparing to baseline or nadir scan, which is the smallest size of the tumor.
So if I had to ask, what are the advantages? What are the strengths? Now we're at the RECIST 1.1 level, as you mentioned. What are the strengths of this technique or this technology now?
Sure. Yeah, so it's actually a common language of efficacy for clinical researchers across disease sites and clinical trial settings. And so it has been used for many of these clinical trials. So it's kind of actually become the common thing that even clinical trials can be compared, because they are using the same way of assessment. And Compared to RECIST 1.0, I think they saw that it doesn't need to have like 10 target lesion. 5 target lesion would give us the response that we need to compare. So it probably will take less time compared to RECIST 1.0 now that we're using RECIST 1.1.
And in terms of modalities, which modalities do you do for RECIST reads? Is it mainly CT or what else?
Yes, it's mainly CT, and sometimes MRI can be used as well, but it's mainly CT.
Okay. And you mentioned it basically is what we use for solid tumors. For example, just give me some of the more common uses of RECIST reads. What tumors typically do you see in your practice?
Um, Many like kind of tumors like lung cancer, liver cancer, renal cancer, melanoma, solid tumors, any kind of like tumors that can be like GYN cancers or anything that is considered solid tumors can be assessed by RECIST 1.1. Yeah, when we say solid, it's compared to like hematologic cancers that are that has different type of assessment. But for solid tumors, like mainly like most kind of cancers that we can see can be used with can be assessed by RECIST 1.1.
And then when you, just to be clear, um, the reproducibility between different users, so one of the things always a challenge in oncology in general, when people read films, some people read it different than other people. And obviously the clinicians always want a consistent read, but what do you do?
So that is one of the disadvantages in anything that like needs human measurement. It is prone to error. There might be variability. I think that they consider that even up to 25% variability is accepted because sometimes even if you ask the same reader or same radiologist to do the assessment again, they may get a little different number. But that is, I think, like one of the disadvantages, that whenever we have human measurement, that error is seen. We can see that.
And we also speak about, you mentioned this at the beginning, that the FDA basically uses this as its gold standard, right? So for new drugs to compare chemotherapy response, whether Keytruda works well on this tumor or not, it's really based on these reads that matter, right?
Yes, correct. Yeah, that's per FDA. This majority of the studies that it has been done to show that like the tumor response rate for solid tumors, um, they've been using RECIST as RECIST one for seeing the how the overall response is and how the tumor response is. So that's kind of like becoming a common language, as I said before.
Now, are there any disadvantages? Are there specific challenges or disadvantages with RECIST 1.1?
Yeah, one thing that we just talk about is that there might be errors, there might be human errors. The other thing that sometimes is we say about RECIST is that it's mainly tumor centric. It's not patient centric. So patient symptoms are not taking into the assessment. The other thing that we might see that some treatments, like immunotherapy treatments, might have a different pattern of response. So that's why when there is limitation with RECIST with those kind of treatment, there's different criteria called iRECIST that take into the assessment for these type of treatment, because the pattern of response is different. We might see pseudoprogression and also like the side effects, the pattern of side effects on the radiologic assessment might be different. So these would be the reason that other criterias came into the picture, like iRECIST.
Okay, so what is, you mentioned iRECIST, RECIST for everyone listening. What is that? What is that? How is that different than RECIST 1.1?
Yes, sure. That's I coming from immunotherapy. That's like immune related and immunotherapy. So there are differences like, for example, in iRECIST, there should be a confirmation of progressive disease response. So if they want to avoid patients who might have pseudoprogression, so that they don't get removed from the trial when they see their progressive response. So there should be another follow-up that this progression would be confirmed, because um, patient might actually benefit of being on the treatment. So this is something that is considered. And if there is a new lesion for RECIST, usually that would cause the assessment to be progressive disease. But for iRECIST, usually that would add it into the overall tumor burden to see if it goes beyond the percentage that is causing progression. So there are some modifications that actually has been done to RECIST so that they consider the different response pattern in immunotherapy, and make sure that they are actually like making the best decision for the patient, considering. Um,
Okay, now, a question, and I'm sure this varies from trial to trial, but how often do you do measurements? So you have certain protocols. Is it every 3 months, every 6 months, every year? What do you do?
yes, exactly. It's based on the protocol. So when the study design, they have an imaging schedule for each study, and they have different schedule. It might be like every 2 months, every 3 months, and it's actually based on how probably like aggressive the tumor is, and how is the how how it will progress really like fast or not. But usually like it's based on the protocol for each study that
Okay, now, in terms of, right now and you mentioned this, one of the challenges with anything when you measure is always human error. So obviously
yes.
you train people. So I guess, what's the challenge of training radiologists? I mean, every radiologist is trained to read CTs, and they look at cancer and they say it's bigger, it's smaller. But what more do you need to do to really do the RECIST criteria?
So one important thing when training radiologists is that they should know that at the baseline scan, choose the best targets. For example, we use the term that the lesions should be reproducible, but what that means is that like they have to make sure that the lesion that they are selecting over time, it can be consistently measured. So for example, if it's a peritoneal lesion, the location of this lesion might change in the next time point based on how the bowels move. So that might not be the best and reproducible lesion. If there are other lesions, they should try to select other lesions. So I think probably based on like the more they practice, it's they can actually see like, was it a good target that I selected at the beginning for this case or not, and how they can um, actually like make their selection of targets and non-targets the best they can at baseline.
So, from a practical thing, if you have a typical trial, do you have
Yes.
multiple readers look at the same cases?
Yes, so the workflow sometimes is like double read. So two radiologists will read see the same case, and there might be some adjudication that if they don't agree about the assessment, a third radiologist will come and choose among those. So some studies might have this workflow. Some studies might have only one radiologist that they see each case and the
Mhm.
follow-up time points.
So, I guess, human error is always going to be there, the human variability, right? Particularly in challenging cases, which we all know sometimes It's not as easy as measuring a lung nodule often. Um, Everything we read about these days is AI, right? AI is everywhere in everything we do. Do you see the, looking forward, there's some work obviously that needs to be done, but do you see something like AI being used? And then also the second part of the question is, we do measurements. I've always argued, since I've done a lot of 3D work, talking about volumes of tumor rather than measurements. And measurements are a good, they work well, has been proven over time. But if you have things like AI, is there a way of potentially AI replacing the radiologist to get more reproducibility or get things done faster? Do you see any of that coming along?
I think so. I think that's the path that probably we go in the future. I totally agree with you that volume is a better way of measurement than just the 2D measurements or unidimensional measurements. And I also think that that would be like the future, that AI and like automated segmentation will take a lot. And of course, as you said, at first it might need like verification by a radiologist and validation, but that would be the pattern, and probably that will yes, um, like reduce a lot from those human errors that we see.
Yeah. Yeah, I think I could imagine surely where maybe, I don't want to put the radiologist out of business, don't get me wrong. But I could imagine where maybe the computer would come first and draw the tumors, and particularly on follow-up studies, and then the radiologist would basically say yay or nay. Um, I could see where that would happen. That might be a little bit faster for the radiologist, particularly in practice, right? And it may be more accurate. Computers can get very reproducible on measuring things. Radiologists, I'm sure, people have written articles about accuracy. The later it gets in the day, the accuracy you tend to go faster because you're tired or whatever. Um, so okay, so we mentioned the CT is really the way to go for the most part for most studies, but we see more and more of things like PET CT being used, where you're looking at some of the functional. How does that work its way into the process?
Yeah, that's also very important. Um, in RECIST, PET is just like sometimes is used, and is used like to help. For example, if they want to select some lesions, that they make sure that it's also they are hot on PET as well. But there are other studies that use PET, and they have the main criteria is based on PET and how the lesions are measured, and like the hottest lesions are measured. So I think that is also very important, especially like for the tumors that are we see like PET activity, and sometimes like the both criteria should be considered. The size might still be pathologic or abnormal, but the lesion is not hot anymore. On the PET, it's showing that it's not hot anymore, so they can like override and say, okay, this can be considered as response, although the size is still um, more than pathologic limits. But yeah, so I think that is important, and for so many of the studies that use PET, that can be the main part of the assessment.
Okay. And similarly, things like bone scans, I mean, doing prostate patients, you build the same thing in with bone scans the same way?
Exactly. Bone scans, like they have for prostate cancer, they have their own criteria. It's called PCWG 2 and 3. So they are actually like counting the number of hot, the number of bone lesions on the bone scan, and see over time if there are new bone lesions, or if there the bone lesions that were new are still showing. So that the because what we might see on CT for the bone lesion might not necessarily be as helpful as the bone scan. They might show like increase, but it's actually response to the treatment. So the bone scan would be the best measurement, especially for prostate cancer, and it has its own criteria.
Okay. So, we've come a long way with RECIST 1. In your opinion, what's the next step in the assessment criteria for cancer, and where do you see things changing over the next couple of years?
I think as we talked also, like volume will take uh, will be more and more important in the assessment of cancer, and the way the more it can be done automatically, it wouldn't be as time consuming, and it would be easier. But I think what I see in the future is that will probably become more and more important, and will be more trials using the volume of the lesions and
Okay.
measuring that over time.
And who basically comes up, is there an organization that really runs creates the criteria and modifies them? Is there a set group of people?
So these are usually like committee of people, I think, in Europe and in US, and they are like publications that they have. That's how these criteria came up, and um, sometimes they're like um, there might be multi-center studies that if there needs to be a change or modification to the criteria or a new version, but usually they're like these committees that, for example, it was RECIST 1.0, then it was changed to RECIST 1.1. And
So, being practical also for many of the people who'll be listening now, I will say that I made a mistake, and when I hit the Facebook Live where this is going to my personal account, not the CTisus. So when we finish this, it's going to go to CTisus, and then we'll have the questions after. But unfortunately, that we're not going to have the questions live. But if people want to know, if you're a resident or a faculty or just an attending, and you want to know more about the RECIST reads, where do you recommend people read about it? Are there some good articles, or is there some special place to go and look and learn what to do?
there are articles like the main article about RECIST um, is like if you search on it is on PubMed. So the main thing that it explains everything about the criteria is on those articles. But I think sometimes, like in practice, when you start doing a case, then you come into some questions that might be um, a little more challenging, and you need like someone to tell you, oh, what I should do in this situation, how this can be handled. But the main thing is on the articles that all these criteria all have
Okay.
original article.
And just out of curiosity, I know you're part of a company, Imaging Endpoints, that does this. That's your business. How do you maintain quality? I think the biggest thing, companies, trials, everyone is always worried about data integrity. How do you make certain? I mean, obviously, your goal is the most accurate studies possible. You have no ulterior motives, but how do you make sure that, everybody, if a lot of people doing the reads, how do you make sure that every study is done as best as it could be within the realm of human error you can't control?
Yes, sure. So the first thing when we start is like we try to train our radiologists like the best way based on the study criteria and if there are any other details. So there would be a training session that go over all the details and how they should work on that on the cases for this study. And then after that, usually there are some training cases that they work on to make sure like it will go after on medical QC to make sure that they understand everything correctly. And after that, when they're working on their scan, there are some logic checks that are built in the software to make sure like the criteria is followed. And there is also another QC that is done after each read is done, again by one of our data management team member to make sure that they follow everything correctly. So we try to do it in multiple steps to make sure like they understand and they are trained correctly, and then they follow those rules throughout their assessments of the cases.
And so, where are the, I mean, no one's perfect, but where do you see the most errors? Is it just human error, someone just not seeing something, or just putting the calibers wrong? I mean, what are the common errors you see? What hints can you give people?
Um, well, about common errors, I think like I, I I was thinking probably what um it might be important is like to make sure like they for example they choose the longest diameter to make sure like they are not missing any new lesions even if they are small, like based on what is the primary disease. They should know like where to look. For example, if it's a ovarian cancer, make sure they look for peritoneal metastasis everywhere. So just to make sure they don't miss anything, they don't like and the other thing is that to take the whole picture into assessment. If they just see one lymph node is enlarged and the other things are responding, they can wait to make sure there's no other reason, there's no infection or anything that caused this. So just to make sure they take the whole picture into their assessment before making any judgment about the response.
Okay, and then, so what, are there any specific studies you've seen that are the most challenging? Let's say, colon versus pancreas versus lung cancer. Are there any that are most difficult to do, most challenging?
I would say sometimes melanoma, because they can go everywhere. That might be a little harder to check for everything. Like, but and yeah, sometimes also might be uh, GYN cancers that they have to make sure like they check everything. And like as I said, peritoneal metastases are easy to miss, so they should make sure like they follow everything. um, yeah, these are the things that might be a little bit more challenging, that they have to check really carefully.
I guess one thing you don't control, and nor do we, nor does anybody, is the quality of a study that's performed. If a study is not done well, if the patient's breathing, if the contrast wasn't injected correctly or fast enough, if the timing is off, things obviously change. How do you deal with that? Because I mean, you don't really you don't often, the people even us reading the studies here, I don't control the study. We have the protocol, but sometimes things aren't followed. I mean, typically we all have protocols, but that doesn't mean every study is the same.
Yeah, that's true. The way we do it is usually we have a questionnaire about the quality of the scan. So if they think like it's suboptimal, or if they think like they cannot make an assessment on this scan, they're like um, the contrast has issue, or their motion artifact or something. So they they would say and explain why they cannot make a good assessment on the scan. So yeah, I agree that there wouldn't be that much control over it. The only thing we can do is that we can decide whether is acceptable and the assessment can be correctly done, or no, it wouldn't.
Okay, good. All right. So, um, anything else you want? I mean, we're kind of at the end of our time, and I think we've covered it really well. I think hopefully, I think for people who really didn't know a lot about this, I think hopefully people now understand how important it is, and how it really is something that the oncologists basically want from all of our studies, right? The oncologists, Dave Ettinger, who's a very famous Hopkins oncologist. Dave's very senior now. His main focus is lung cancer, but when I was very junior, he used to come around with these 6-inch rulers and give you as a radiologist, he'd give you a ruler. Now, those were the days we had film, right? So you needed a
Yeah.
ruler, but he gave you a red ruler, and the back of the ruler said, "Measurement is science." And,
Yes.
as the term "it's bigger is smaller" obviously sounds great, but that's not science. And so, any last comments you want to make to the audience about
Uh,
how they can
oh,
do better?
thank you. Yeah, it was
Okay.
a nice conversation.
Oh,
Appreciate it.
yeah, that was wonderful. Now, because I did screw up, what we'll do is for the audience, so they can they'll hear us in a few minutes when I take this and put it on Facebook, is people can ask questions and then I'll try to answer them. But what I'll try to do is I'll get back to you and you'll be able to answer the questions for everybody. Okay.
Sure, I'd be happy to do that.
All right. Well, I thank everyone for attending, though I feel bad that you're going to be there a little bit late. And I want to thank Samira for doing a great job and explaining everything we wanted to know about RECIST 1.1, but we're afraid to ask. Thanks
Thank
very
you so
much.
much, Dr.
My
Fishman.
pleasure. My pleasure.
Bye.
Have a great day.
You too. Bye.